Welcome, everyone, to the March 8th Board of Directors meeting of the Washington Township Hospital District. Call that meeting to order and invite all those that can to join me in the Pledge of Allegiance.
Have your attention, please.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, everyone. Cheryl, if you could take the roll for us.
Director Stewart,
Present.
Director Nicholson,
Present.
Director Wallace, Director Yee,
Present.
Director Epen.
Present. Thank you very much.
You're welcome.
Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible on Zoom. I ask that you mute your system until such time as you need to speak. We are recording tonight's regular session board meeting, and it will be posted on our website for future viewing. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statements. Not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none, we'll move on to the consent calendar. The consent calendar consists of those items that we will vote on as one item. If there are any members of the board who desire any item to be removed from the consent calendar, accept any action on that. Does anyone of the public want to remove any agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar, items A, B, and C?
I move that the Board of Directors approve the consent calendars items A, B, and C.
I'll second that.
We have a motion and a second. Cheryl, if you take the roll on that.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace, Director Yee,
Aye.
Director Epen.
Aye.
Thank you. That motion passes, and the consent calendar is passed. We are now ready to move on to some presentations. Kimberly, if you could introduce that for us.
Yes, thank you, Dr. Stewart. It is my pleasure to introduce, to begin with, Dr. Prasad Khatta. Dr. Prasad Khatta graduated in medicine from the University of Gulbarga, India. He completed his residency in internal medicine at the University of Medicine and Dentistry of New Jersey in 2002 and fellowship in endocrinology and metabolism from the Charles R. Drew University /UCLA in 2004. He is board certified in internal medicine and endocrinology. Dr. Khatta began his career at Washington Hospital in 2004 as an endocrinologist. In 2008, he joined the Washington Township Medical Foundation. In 2014, he became the medical director of the diabetes program. And Dr. Khatta is truly committed to improving the health of his patients and their communities through quality and compassion. And he is dedicated to establishing a comprehensive diabetes program at Washington Hospital. So he and Lena Wong, and I'm going to introduce Lena. She's a pharmacist who has worked on multiple improvement projects related to diabetes for more than 20 years at Washington Hospital. She is board certified in advanced diabetes management and a board certified pharmacotherapy specialist, Lena became the clinical manager of diabetes program in 2021 and is now passionately leading the efforts to advance our diabetes program with Dr. Khatta. So the two of them are here this evening to talk about our diabetes program and also our journey to Joint Commission certification. So thank you, Dr. Khatta and Lena, for joining us this evening.
Thank you, Kimberly. Can I share my slides from here? Is that okay?
Sure, Doc. Please go ahead.
Yeah. Can you see my screen?
Yes, we can see the slides.
Okay, so let me just start the slideshow and then. So we're talking today about Joint Commission inpatient diabetes certification. This has actually been in the back burner for some time, and it has sort of, I would say, definitely taken to some patient, because with respect to Kimberly coming in as the CEO, and also our CNO and Vice President Larry Lebossiere, and also Lena taking over with respect to the outpatient diabetes management manager. For that reason, I think it's sort of definitely in the limelight right now, and I think probably in the next year, we'll probably try and get the certification, or at least apply for the certification and try and get it going. So my slide shows about 25, 26 slides. I will be talking about what is diabetes, the diabetes prevalence in the national and also the local settings. I'll also be talking about complications, just touching upon the complications, and with respect to how diabetes affects the hospitalized patients, the benefits of having a Joint Commission certification for diabetes, and with respect to Washington Hospital as a system or healthcare system, to journey to excellence, and where we are in applying for this certification and what we need to do. So what is diabetes? It's actually a chronic, long-standing health condition, and as of now, there's no cure for it yet. So how does it happen? The body does not make enough insulin, or it cannot use or utilize the insulin as it should. Even though you're making insulin, you're not using it or utilizing it as you should. As a result, basically the body cannot transform the sugar into energy. So the sugar, glucose, builds up from the food which we eat in the bloodstream and causes high blood sugar levels. So there are different types of diabetes. The type 1, where the body does not make any insulin at all. So the pancreas, which is the organ which is behind and beneath the stomach, does not make any insulin at all. And the type 2, which is the body does not make enough insulin, there is a relative insulin deficiency, or it cannot use insulin, as I discussed earlier. And gestational diabetes, this is a type of diabetes which develops in pregnant women who have never had a history of diabetes, but can be at risk of diabetes from the point of view of if their parents are diabetic, etc., or if they previously had gestational diabetes. So in this cartoon figure, if you look at it, basically glucose enters the bloodstream from the intestines when we digest our food, and the insulin enters the bloodstream from the pancreas. And in a normal person, what happens is both of these enter, and the insulin binds to the cells and lets the glucose in, and the glucose is used as energy. This is in a normal person, and it happens seamlessly. But in patients with diabetes, there is definitely blockages in what we discussed earlier. In type 1, there's no insulin, and in type 2, we don't make enough insulin, or there is also what we call as insulin resistance. So who has diabetes? More than about 37 million patients, that's about 11% of the population has diabetes. Type 1 only accounts for about 5 to 10% of the patients. Most of the patients we see, both outpatient and inpatient, are type 2 diabetes. This is 90 to 95% of the patients. And who is at risk for developing diabetes? If you have a pre-diabetes, then you are definitely at a risk for it. If you are overweight, if they are 45 years or older, physically less active than 3 times a week. Also, if you have had a history of gestational diabetes or given birth to a baby who's weighed more than 9 pounds. And also there are racial risk factors, African American, Hispanic, Latino, American Indian, and Alaska Native person, and also Asian Americans and Pacific Islanders are also at higher risk. How many people have diabetes in America? It's about, again, as I said, 37.3 million, which is about 11% of the population. And the diagnosed is about 29 million. Undiagnosed is still about 8.5 million, which accounts to about 23% of the patients who are undiagnosed. And with respect to pre-diabetes, the numbers are even more staggering. About 96 million patients who are over 18 years, which accounts to about 38% of the adult population. And if you look at 65 years or older, about 26 million people, which accounts to about almost 50% of the patients who are 65 or older have pre-diabetes. So this is coming to our local burden of diabetes in California. If you look at in California, percentage of adults 18 or older, it almost account to, from about 2010 onwards, it almost account to about 9 to 10%. And in the local setting, in the Alameda County, the percentage of patients 20 years or older is about anywhere from high 5 to about 8% of the population. So what happens with respect to uncontrolled diabetes? What are the risk factors? So if you look at the risk factors, there are many here. It definitely doubles your risk for heart disease, high blood pressure, and stroke. And there is also a leading cause of end-stage kidney disease. Majority of the patients who need dialysis is because of diabetes. And it's also a leading cause for blindness and 7th leading cause of death in the United States. So one other thing which is not mentioned here is it's also one of the leading causes for amputation in US. The other things which it can cause is it can definitely have an effect on your heart in other ways. Kidneys, we discussed. It can cause peripheral neuropathy, which can lead to amputation, where the patients may not feel the sensation in their feet and can lead to infections. And it can also cause cataracts and glaucoma. And there is an increased incidence of tooth decay, cavities, gingivitis, early gum disease, and periodontitis in patients who have type 2 diabetes. And we definitely tell patients that they need to see their dentist regularly on a regular basis and take care of their teeth also. And in the long run, definitely diabetes also has an effect on the brain. And there is some correlation with respect to diabetes and dementia, and also low blood sugars and also dementia, which some patients can experience when we treat diabetes. So what are the costs and hospital and admissions with respect to diabetes? I'll just go over the bar graph. This is the 1 out of 3 patients who are admitted to the Washington Hospital Healthcare System had diabetes. This has stayed pretty much the same over the last few years. And what is the cost associated with diabetes nationally? It's the most expensive chronic condition we can think of. 1 out of $4 in US healthcare costs are spent on diabetes or related diseases. About 237 billion is spent each year. That is in direct medical costs, and indirect adds up to about 90 billion in reduced productivity, days off, etc. And about 61% of the diabetes costs for adults are on age 65 or older is mainly paid by Medicare. And again, these I want to mention that the costs were measured in 2017 US dollars, and most likely these numbers would have only gone up as we know with respect to anything in healthcare. So what are the consequences of high blood sugars in hospitalized patients? When we say hospitalized patients, not all of them may be diabetic. Some of them may just have pre-diabetes or even normal blood sugars. But when they are under stress with respect to a hospital admission, their blood sugars can go up. And these high blood sugars definitely damages different organs. And how do they do it? There is definitely decreased white cell, that these are the defense cells in the body, which don't work well, and they become lazy. You can say, we call it lazy leukocyte syndrome, but they become lazy and they don't work as well. And they cause more severe infections, slow wound healing, etc. It also reduces blood flow, worsen heart problems and brain injury, cell and tissue injury, kidneys, nerves, etc. And it also damages blood lining, increases the risk of heart attack and stroke, and also can cause blood clots. So this is one of the reasons we want to pursue for Joint Commission certification. That is so that we can, the glucose management in the hospital can definitely lead to better patient outcomes. So the next part of my talk, I'll be talking about Joint Commission inpatient certification. What do they advise that we need and where we are at. So Joint Commission Disease Specific Certification Program, it evaluates disease management for chronic care services, which provided by direct care providers such as hospitals. The certification can be obtained for any chronic condition. So what do they exactly want from us? One is compliance with consensus-based national standards. It can be American Diabetes Association, American College of Clinical Endocrinology. So we have to have some consensus-based national standards and effective use of evidence-based clinical practice guidelines to manage and optimize care, and an organized approach for the performance measurement and improvement activities. So when we have this in place, the third, obviously we can measure ourselves against other hospitals and improve our guidelines and manage and optimize care. So this is sort of a busy slide with a number of points for the Joint Commission Disease Specific Care Certification. Basically, it's a program which meets clinical performance and standards and regulatory compliance standards. Again, as I said, it can be American Diabetes Association or American College of Clinical Endocrinology. It provides a framework for program structure and management and provides an objective assessment of clinical excellence. We always can feel that, okay, we are doing good to our patients, but it definitely gives you an objective assessment, because the Joint Commission certification, they'll come back and they'll look at what we are measuring and they'll tell you, okay, are we doing good or not? And improves the quality of patient care by reducing the variation. So if we have our protocols in place, the variation on treating patients definitely is reduced, and consistent approach to care, reducing risk of errors, definitely improves the inpatient experience. And to build this, we'll need an organized teams of continuum of care. I'll show you in the slides later on, to create a loyal and a cohesive team. Definitely promotes culture of excellence across the organization, demonstrates commitment to higher standard of clinical service, and strengthens the community in quality and safety of care, treatment, and services. So all this, again, in the end, definitely facilitates marketing, contracting, and also reimbursement. So framework of excellence, so divided into three different parts: structure, process, and outcome. Structure, so how do we go about structure? We need to have a leader, need to have a multidisciplinary team, and how we take care of our patients. Process is basically we need to develop workflows, delivery of care to the patients, and outcome, we'll need to measure improvements and improve our clinical outcomes. So what do they want from us from the point of view of giving excellent diabetes care in the hospital? One is they need for us to start off at the admission process itself, during the hospitalization, and also manage them in the transition of care as an outpatient. So we need to screen patients for A1C, which is the average blood sugar for the last 3 months when the patients are admitted. Identify patients who are uncontrolled, who are undiagnosed, and also if they have pre-diabetes, and stratify the intensity of treatment for these patients in the hospital. And we also will want to have clinical practice guidelines. These will be based on where the patient is. It can be, can be in ICU, patient can be on a regular floor, or in telemetry, or intermediate medical care. So we have different protocols for these patients, and clinician collaboration, which includes the physician, nurses, pharmacists, and dietitians. And also we need to have a transition of care where patient education is done, patient communications with the outpatient providers, because some of the community doctors may not come to the hospital. If the patient is admitted, we have to communicate with them as why they were admitted, what way medications were changed. That comes with medical reconciliation, and prescription of medications and supply. That also is very important, because diabetes is a disease where you need a lot of different paraphernalia, including a meter, needles for insulin injections, etc. Those need to be written properly and refer to the outpatient diabetes education and support. So again, the standardization of care, if you look at, we'll have to implement the clinical practice guidelines, evidence-based protocols for low blood sugars, which is hypoglycemia management and reassessment of the use of device. It also defines the glucose range and treatment of specific population. It can be in perioperative patients who are going for surgery, critically ill versus non-critically ill patients, and persistent high blood sugars or hyperglycemia patients. Glucose monitoring plans based on clinical conditions, and what to eat, what not to eat with respect to oral intake, and desired blood sugar levels for each individual patients. And we have to give them an individualized treatment plan. A lot of it is done usually outpatient, but at least if a newly diagnosed patient, the starting point is in the inpatient, and then we sort of plug them into the outpatient system. So with respect to staff education, we need to have policies and procedures in place to ensure competency and also manage related to the diabetes, recognizing and responding to low blood sugars or symptomatic hypoglycemia, and policies and procedures for insulin pump and continuous blood glucose monitors. So the continuous blood glucose monitors are becoming pretty much standard of care nowadays in outpatient, and Medicare actually has made it more lenient or more easy to get these continuous glucose monitors in patients as outpatient. 3-4 years ago, it would be very difficult. At this present point of time, it's a lot more easier, and a lot more patients will be coming into the hospital with respect to continuous blood glucose monitors. And also patient education, glucose monitoring, when to take medication, how to recognize and prevent high or low blood sugars, and also sick day management. With respect to this, you need to have a good inpatient educator, and in Washington Hospital Healthcare System, we do have that. So the sum of requirements, program management, like program leaders and team, safety protocol to prevent insulin errors, because insulin errors is one of the most common errors which occurs with respect to the hospital, and we have a robust program for that. Ongoing initiatives and performance improvement. With respect to performance improvement, clinical processes, we do evaluate the glycemic outcomes data and also are a part of the Society of Hospital Medicine, so where our data is submitted, and we get ranked against the other hospitals in the country. A process to review low and high glucose levels, patient satisfaction survey, and continuous improvement of processes and protocols. So again, as I said earlier, standardized order sets for insulin pump, defined criteria for patients who must be seen by a registered dietitian during the hospitalization, and transition of care where we plug this patient into the outpatient system, or at least give information to the primary care physician who the patients belong to, and why the patient was admitted to the hospital, and what we have done with the patient with respect to the taking care of the blood sugars in the hospital. So if you look at the final product, if you look at as evidence-based diabetes care, hospitalized patient is in the center here. We have a hospitalist or the primary care provider who is taking care of the patient. We also have nursing, the diabetes educator. We have case management who's looking into what the patient needs. We have a dietitian who sees the patient when they're in the hospital, pharmacist, and if need be, an endocrinologist like myself. So we are trying to use measurable results. We are also trying to streamline the process and improve safety. So where do we stand with respect to Washington Hospital for glucose management and our journey to excellence in getting the Joint Commission accreditation? All this definitely will have a cost, I think, with respect to Joint Commission for applying it and also maintaining it. There's a cost involved. And in the next few slides, I'll be showing where we are currently at. So we have a comprehensive diabetes program here. Inpatient, we have a standardized care. We have collaboration among providers and diabetes care in all areas. With respect to transition of care, we have education in place for the patients, and we plug them into the outside resources, that is the outpatient diabetes education program, which is ADA certified. And the primary care follow-up again here for the outpatient, and outpatient diabetes program, which is gives self-management training to the patients. And we also do a lot of community engagement, which is a support group and community education to patients, where different providers can come and talk to patients with respect to their diabetes needs, complications, etc. So again, our journey towards excellence, the puzzle pieces, these all have been implemented with respect to our Washington Hospital healthcare system. We have a hypoglycemia management in place. And this over the last 1.5 years, if you, the graphs show that we are in the top quartile. The protocols and order sets for standardizing treatments are in place. Benchmarking the quality data, as I already discussed, we do benchmark our data into Society of Hospital Medicine. Critical care glycemic management program has been there for some time. And recently we also implemented our perioperative glycemic management program. These are for patients with respect to for going in for surgery, can be day surgery, or if they're coming in for surgery and staying over. And the diabetes education. So the clinicians collaboration, the nursing monitoring, pharmacy dosing has been going on for some time. We've had it for at least more than 10 years, and 90-95% of our patients are usually managed by pharmacy protocol. Dietitian consults, a lot of these patients with respect to who have diabetes get seen by a dietitian. Physician intervention if needed. and also with respect to the Epic Care team, which helps us with a lot of these different protocols and standards. So there are about 56 hospitals have joint commission advanced inpatient diabetes certification. So if you look at the number of hospitals in US, that's not a lot. And it is actually very difficult to get it. So that's why most of them don't go to attempt to get it. That's what I've learned and heard. So I think if we are able to do it, it would be a really good thing for the patients and also a good thing for the hospital. So where are we at for the application process? We need to, in the pre-application process at this point, we pretty much have a lot of things in place for the clinical practice guidelines. We need to choose 4 performance measures and the performance improvement plans for those performance measures, and then submit the application, select a ready date, and 4 to 6 months after the application. And then after that, there'll be an on-site review. We'll get an advance notice for 30 days before, and we'll provide them the 4 performance measures data for the most recent 4 months, and it'll be a 1-day review. So the goal at this point of time is apply within the 9 to 12 months period and get the Joint Commission accreditation. So that's the pretty much end of my talk. Again, I would like to thank CEO Kimberly Hartz and CNO and Vice President Larry Labossiere. And again, from the point of view of the Diabetes Advisory Committee, we've got a lot of help from our CEO and CNO and Assistant to CNO, Tigges Stavel, and Pharmacy and Dietary Services. Thank you. If you have any questions, I'll be more than happy to answer.
Dr. Kata, is there any role for continuous glucose monitoring in the hospital? I know that's been a huge revolution in outpatient care. My question is that going to be useful or appropriate for inpatient care?
Thanks for that question, Dr. Nicholson. At this point of time, there is none. When COVID was really, when we were at the heart of COVID season, like about 2.5 years ago, I think FDA gave like, either the FDA, I think the FDA gave an option that you can use continuous glucose monitoring in patients who are really critically ill and you don't need to check them for some amount of time, and they were using the Dexcom sensors at that point of time. But I've not heard anything that it is a standard of care in any of the hospitals and they're using it on a regular basis.
Okay, thank you.
Any other questions? Dr. Kata, thank you. Thank you very much. And Lena, we appreciate your report tonight. Diabetes is a very, very important part of our society as you've presented today. And we appreciate bringing up to date on that. I'm looking forward to a certification. That would be wonderful. At any rate, thank you very much to both of you. Very informative and helpful.
Thank you. Appreciate it.
We can now move on to our reports. First of all, invite Dr. Shakir, our Chief of Medical Staff, to make his presentation on the medical staff report. Good evening, Doctor.
Hi, good evening to all. Thank you so much. So, first of all, there is a bit of little good news for us that hand hygiene, the numbers have, Ms. Gulnaz has sent, and it is 81%, which is a little better than before. Of course, the goal is to have a 95%, but it is all included, the physicians and all that. So they are trying. Hopefully we'll reach that. And The second thing is our medical staff number has gone up from more than 600. It is 605. We have about in medicine 264, family medicine is 43, and anesthesiology is 29 as total is, and OB-GYN 32, pediatrics is 59, radiology is 46. So we have active medical staff members are 341, administrative 1, advanced practice providers are 39, ambulatory 96, consultation is 7, courtesy is 27, leave of absence are 2, provisional active are 47, provisional APP is 22, provisional consulting is 9, and provisional courtesy is 14. So we have a grand total of 605, which is pretty high. I mean, we are really, the medical staff is really busy credentialing the new applications. So, and the other thing is we are looking forward to have a doctor's day and also dinner dance, and administration, Ms. Hartz is, putting a lot of effort to take care of that, in a systematic way. And we are going to have a generalist medical staff meeting this next week. So this is my report.
Thank you very much, Dr. Hyder. Are there any questions for Dr. Hyder? Appreciate your report, Dr. Hyder. Nice
Thank you. Thank you so much for all the.
To have such a wonderful number, that 605 is very.
Yeah, it's a great number.
Yep, thank you. And now move on to our Service League report. Sheila Vijay, we're ready for your report.
Would you like me to maybe do a quick introduction of Sheila?
Sure. I'm sorry.
That's okay.
Sheila is brand new to the...
Well, she's brand new to the role, but I know she has actually presented to the Board of Directors in the past. But I do want to warmly welcome Sheila.
Welcome, Sheila.
Yes.
I apologize for not being more appropriate with my introduction.
Yes.
Sheila, it's nice to have you with us.
And I'll give a little bit of an introduction of you, Sheila, just so that everybody is aware. She has volunteered at Washington Hospital since 2019. In 2020, she began serving as the first vice president of the Service League. She has fulfilled many assignments, including in the emergency department, infusion center, special care nursery, and the pharmacy. And she also really helped the healthcare system when she assisted in the COVID-19 test kit assembly and labeling the COVID-19 syringes with many of the other volunteers who helped us. Sheila also serves as the senior trainer for the Nurse Unit Assist program that supports the Med-Surg units, the emergency department, and the infusion center. Prior to her work at Washington Hospital, Sheila was a principal of a private school in San Jose with a student body of 900 students and managed a faculty of 100. Previously, she taught all grades, kindergarten through 5th grade, for 10 years. While living in India during her early years, Sheila volunteered with blind children, served in old age homes, and helped to build homes in flood-hit areas. So we welcome you as now our Service League president.
Thank you, Kimberly. Dr. Stewart, I'm so proud of myself. I remember to unmute myself this time. So that was a big thing. I have unmute written everywhere here. All right. Good evening, members of the district board. Greetings from the volunteers. My name again is Sheila Vijay. I'm the new Service League president for 2023-2024. I joined Washington Township Hospital Service League as a volunteer after I took an early retirement in 2018. I was pleasantly surprised to be in the limelight when I was made the first vice president of the league in 2020. Currently, I'm a senior trainer for the Nurses Unit Assist program and the infusion center. I volunteered in the Nurses Unit Assist, emergency department, special care nursery, pharmacy, and in many other areas. These last few years at Washington Hospital, I have to say, have been immensely rewarding. I wasn't very sure after I left my job how satisfied I would be, but it's been very, very heartwarming to be able to make someone's day a little brighter. I learned a lot about the inner workings and nuances of the Service League while serving as first vice president, and I hope to put that knowledge to good use this year. On Friday, March 3rd, the members of the Service League seated a new board of directors. In addition to me serving as president, the new officers will be Shuri Gamardo, first vice president, Jill Zeman, second vice president, Carissa Barberi, treasurer, Marlene Iamura, secretary, and last but not least, Gail Tomita, parliamentarian. I'm confident that we have a very strong board this year and one that is committed to the Service League. It's my honor to serve as president for the coming year. As the League's new president, I look forward to collaborating closely with the Healthcare District Board of Directors and the president, Dr. Bernard Stewart. Now for my monthly report. In February, our Director of Volunteer Service, Evangeline Imana Iamura, and I were invited to give a talk to the California Association of Hospital and Health Systems, known as CAHS, Volunteer Conference in Sacramento. This was their first in-person conference since the beginning of the public health emergency. The topic was volunteer roles adapting to meet current needs. It was a proud moment for us to highlight Washington Hospital and our volunteering program to a group of approximately 40 attendees. We spoke about the history of Washington Hospital, pre- and post-COVID-19 volunteering in our Nurse Unit Assist program and the emergency department. The presentation was very well received. The training that we provide our volunteers on the Voice Medical Interpreter iPad was especially lauded. The big takeaway from this conference was that the volunteer population has changed. Hospital has seen a decrease in older senior volunteers. Gift shops in some hospitals have not reopened due to a lack of funding and volunteers. There are continuing struggles with recruitment deficits and slow onboarding. On the whole, it was a wonderful conference where hospital directors of volunteer services and volunteers could network and share best practices. I came home with lots of information and ideas, and I hope to share that with the Service League board. Moving on to the news from our hospital. In the past month, 203 members of the Service League volunteered 2,086 hours. We are in the process of identifying more trainers for our program. Our goal is to develop young volunteers so they become leaders in their chosen fields. WOOF canine therapy teams continue to visit the hospital, helping patients heal emotionally, physically, and mentally. Our quilting group has been hard at work. They have produced a beautiful quilt that's ready to go on sale at the gift shop very soon. I hope to be able to bring other areas of our volunteer program to your attention in the coming board meetings. And that's all I have for you today. I want to thank the board of directors and the hospital for your support to the Service League every year. Please let me know if you have any questions.
Are there any questions for Sheila?
When is the masquerade sale?
May 1st, 2nd, and 3rd.
Okay, thank you. I'll put it on our calendar.
Thank you for the
Good.
plug.
Yeah.
That's also a very important event.
Yes, it
All of
is.
us
Yes, it is.
enjoyed-
I'm glad I had the date ready with me.
Sheila, question, when you were at CAUSE, talking with volunteers from other hospitals in the state, do any have a program like we have for volunteers going into ICU and the ED and the Nurse Unit Assist program? Does anybody else have a program like that?
They do have programs like that, but interestingly, they seem, at least one of the hospitals I spoke to, seemed to allow high schoolers to go into patient-facing rooms. So, which was a little bit of a surprise to me, because we allow only college and adults to go into patient-facing rooms. Many of them haven't opened yet. They were just there to gather information on how we have started the program, in terms of safety and so on. And And some of the hospitals, the volunteers haven't returned. They're still afraid to come back to the hospital. So we are in a very, very lucky place because we have all our volunteers so ready to come back. And many gift shops are not open yet. Does that answer your question, Jeannie?
Yes, thank you.
Thank you very much, Sheila. The Service League is a tremendous asset to the hospital.
Thank you, Dr. Stewart.
We truly appreciate all that is done there. And it's also nice to hear that we're up and running where many others are not. That's a wonderful, wonderful accomplishment.
Yes, I was surprised when I heard many of them hadn't opened yet. They were just there to gather information on how to go about opening their hospitals.
You know, the Service League does a lot of great work. But I have to say, in addition to all of that, there are some really, really good people associated with that organization.
Yes, absolutely.
It's always a pleasure to meet with any of you or all of you. It's a great, great group and a real asset to the hospital. We appreciate your work.
Thank you, Dr. Stewart.
Thank you very much, Sheila. We're ready at this point to move on to our quality report, which will be given by Mary Boron. Kimberly, do we need an introduction for Mary, or do we?
I think we all know that Mary is our Chief Quality Officer, and she's going to be giving the quality dashboard for the quarter ending December of 2022.
Thank you. Mary, it's good to see you. Good to hear your report.
Great. Thank you for the opportunity to present this tonight. This is a reflection of data from October, November, and December. And so it's quarter ending 12/22. Overall, we had a great quarter with a lot of metrics meeting goal. And we do have some areas for improvement around readmissions, which I will get to towards the end of the presentation. But starting off with the infection prevention indicators, we have first our MRSA, which is a bacteria that's very difficult to treat in the blood. And I'm happy to report that we had 0 MRSA infections in this last quarter. And we have actually exceeded a year without any MRSA being identified in patients' blood 72 hours after admission. So this is a great reflection of transmission-based precautions being in the hospital, giving us 0 MRSAs. Our catheter-associated urinary tract infections, otherwise known as CAUTI, we had 0 for this last quarter. And the CDC predicted that we'd have closer to 1. And so that is less than expected. This is also a metric we've been doing a lot of work on in the hospital. This is a nursing sensitive indicator, and it is reflective of some really great work around the nursing staff on maintaining catheters when they are placed in patients and using our nursing driven protocol to ensure that the only patients in the hospital that have catheters are ones that meet medical necessity for a catheter. We work really hard to get them out as soon as they are no longer needed and maintained very well while they're in place. Central line associated bloodstream infections, otherwise known as CLABSI. This is another great outcome, also a nursing sensitive indicator. We had 0 CLABSIs in this last quarter, and this one is coming very close to a year. We're at 295 days right now without a CLABSI, so we're about 70 days shy of a year. And we're really working together with the multidisciplinary team and the medical staff to make sure that our central lines are only in patients who need them, and again, removing them when they are no longer necessary, but also when they're in place, maintaining the central line, doing appropriate dressing changes when needed, and being very careful with how we maintain it on a daily basis. And I think you can really see the outcome from all that work that's being done around CLABSI prevention. Our surgical site infections, we've had some great outcomes with low surgical site infections in general, starting off with our colon surgery, which is a high-risk procedure for developing a surgical site infection. We have had 0. And as you can see, we are well over a year here again with no surgical site infections with our colon surgeries. Very similar results in abdominal surgery hysterectomies. We had 0 this last quarter, and we have had a steady over a year again of a very 0 surgical site infections. And of these 2 procedures, one of the reasons why the CDC and CMS ask us to monitor these and require it, in fact, is because they want to take a metric and use it as an outcome of how you do room turnovers in the OR, how the surgical procedure is performed, are you following all sterile precautions, et cetera. And so this is really an outcome measure of really good OR procedures and post-op procedures. C. diff is also an infection that is very difficult to treat with antibiotics, and it is something that we have been working really hard with multiple areas of the multidisciplinary team on this, and we have had, again, another quarter where we had far less than predicted by CDC. We had 3 C. diff infections the last quarter. The CDC predicted that we would have about 9 infections, so this is significantly less. And as you can see from prior quarters, we're really sustaining for an extended period of time a much lower C. diff infections than expected. And this is a result of making sure that we are testing stool appropriately in the hospital, and also the bigger picture of it is really having strict, good antimicrobial stewardship. Our program here is very well developed, and we monitor the use of antibiotics very carefully. And this is one of the outcome metrics that really displays the strength of that program. And again, the team working on making sure that we're testing stool appropriately. Another good quarter for that. Hand hygiene is an area that we did see a decline on in this last quarter. We went down to 78%. The World Health Organization's benchmark on this is 70%. So we did exceed that benchmark, but we're not quite where Joint Commission, which is would want us, which is at 90%. We do recognize that this is an area that we need to work on. We do have a team with the Patient Safety Committee looking at this, giving it a great deal of attention to make sure that we have more observers out working with the staff, trained observers, really having good communication when we notice that somebody on the healthcare team has not washed their hands, and trying to learn for what was the reason why they didn't wash their hands, or what are things that we can do to improve the environment in the hospital so that healthcare workers have good access to washing their hands and everything that they need. They're not interrupted as they're going to wash their hands, things like that we're looking into. So we do recognize that this is an area that we need to be working on. And again, quality is working very closely with Patient Safety Committee on this. Moving into additional nursing sensitive indicators about falls for patients. We did have a quarter, again, of less than expected falls. We did have, this is a reflection of 2 falls, and these were minor falls in patients. One patient fell and had an abrasion, and the other one had a laceration. One was elderly, and then another one was a little bit younger, but dealing with some medical problems and confused and fell. But however, even though 2 falls we do take seriously, again, very minor injuries. But I think the bigger picture says that we've had an extended period of time, well over a year again, where the patients have always had less falls than expected for a hospital of our size and type. And this is really a reflection of the whole team working together to make sure that patients are assessed appropriately, and if they're identified as having a high fall risk, that they're put closer to the nursing station, they have frequent rounds, and even when a patient does have a fall, they immediately huddle and do a debrief on talking about what could we have done to prevent this fall. So I think all of that work is really reflected by these multiple quarters at being far less than expected for falls. Our hospital-acquired pressure ulcers, otherwise known as bed sores, we had 0 of those for the 2nd quarter in a row. The national rate's about 1.7%, and so for us to have 0, this is a great outcome. Also, this is reflective of nursing care that is really on a magnet level. This is a nursing sensitive indicator, and it really reflects nurses being in the patient's room, rotating the patients appropriately, making sure they're on the right mattress. And nutrition is another important part that we monitor for patients who would be at high risk for developing a pressure ulcer. And by the whole team working together and communicating well in these cases, we can see another great area of outcome here. Moving into our readmissions, starting off with our AMI, otherwise known as a heart attack, we did have 6 patients come back within 30 days of being discharged. That is out of 24 patients, putting us at 25%, which is higher than what CMS would expect. They expect about 15% of these patients to come back. All of the cases of patients that come back and are readmitted are reviewed by medical staff who understand the patient's diagnosis and what's going on. And we look at these with the transitional care team and the readmissions team. And in these 6 patients, we did find that all of them were medically necessary to come in and be admitted to the hospital again, which we take very seriously. If a patient needs to be admitted, of course, they're going to be admitted. We did notice some area for opportunity in a couple of these patients around medical medicine management. So we'll be working closely with the transitional care team, looking a little bit more about the patients and understanding their medications, the importance of taking them, etc. But there were other ones that were just had nothing to do with what you would typically find would put somebody at risk for readmissions. Like, for example, we had one of these patients came back with cellulitis, which was totally unrelated to their cardiac condition. But so it's a combination of both. Pneumonia is an area that we really struggled with in sort of mid-2021, and we've given a lot of attention to this high-risk population. And this quarter, we had 5 patients readmitted out of 47. That does put us at 10.6% of readmission rate for pneumonia patients, which is less than what CMS's benchmark is at 14.8%. These patients, again, are closely monitored prior to discharge as they are identified as high-risk patients for readmission. And our team works closely to make sure that they have a follow-up appointment with their physician within 7 days of discharge. Again, understanding their medications and watching and understanding their discharge instructions, working with the family to help educate, etc. We also have been following up and calling these patients afterwards. We have 2 teams that do that. One is our transitional care team, focusing on more of the nursing elements that the patient should be watching after discharge. And then we also have pharmacists that call them. And again, we could see a steady decline, and we're working towards sustaining that. Heart failure is another area that has been a struggle in the past year of 2022. But as you can see, we're on a steady decline here. We have 9 patients that were readmitted out of 56. That 9 put us at 16.1%, and CMS national benchmark is about 21.3%. And again, very similar approach to this patient population, as I mentioned, with pneumonia, and we will continue to focus on this high-risk group and sustain and hope to get it down further. Chronic obstructive pulmonary disease, otherwise known as COPD. We did have less than expected on this. We had 3 patients that came back out of 20. That readmission rate is 15%, and CMS's national benchmark is about 19.8%. So again, less than expected. Also a very challenging patient population as they are suffering with this chronic illness. And we do the same interventions as I mentioned before with pneumonia and heart failure. Coronary artery bypass graft, otherwise known as a CABG, we did experience some readmits in this patient population. We had 2 patients come back. One thing I do want to point out, it's a very small group of patients. There's only 6 patients over the quarter that are in this, and 2 of those patients did come back, putting us at 33%. The national benchmark on this from CMS is 11.9%, and these 2 patients actually came back totally unrelated to issues with their CABG surgery, and in fact unrelated to cardiac issues. So again, they both met medical necessity to be readmitted, and they were readmitted late in the course of the 30 days. One was at 20 days and one was at 22 days. Our total hip and knee replacements, did go up this quarter with only one readmission. So we did only have one readmission. Again, the denominator is low if this was out of 8 patients, but with just one, it'll put us at 12.5 readmission rate. CMS expects this to be very low, 4.1%. And in this one patient that came back, this is a patient who actually had their knee replaced and on day 24 came back, and this patient came back related to a hypertension crisis. And because it was a patient who was dealing with dialysis, this patient absolutely needed to be admitted, and they were able to get their hypertension under control. We did a lot of medication re-education with this patient. I do think that that was one opportunity, as the patient did not appear to be fully taking their medications as directed. So again, just another area of opportunity working with them. Patient was discharged home fine and did not have any further complications. And that is the end of my report, and I'm free to open any questions. Thank you.
Yeah, Mary, we do a lot more heart surgery and knee replacements per quarter than the index discharges would say on these graphs. Why are the denominators so low? Are these looking at solely Medicare patients?
Correct.
Or are they looking at a sample? And do we have the opportunity to expand the denominator so we don't have the statistical anomalies associated with small sample size?
Yeah, thank you, Dr. Nicholson. There's you're correct in fact that it is only the Medicare patients, it's only CMS. And the other thing is with the knees and hips, it is only inpatient. So as you said, it's one of our largest service lines, right? And we have great outcomes when you look at the entire population. The way that the HRRP program is set up in CMS is it only looks at inpatients that are Medicare. So when you do that, and when you're looking at right now, only about 10% of that service line is inpatient, and they're high risk. If you're inpatient now having your knee or hip replaced, it's typically because you have maybe some comorbidities or other risk factors, and that's a small group of that patient population. So that's why the denominator ends up looking so low. Now, to answer your second question about can we look at more, we absolutely can. We are actually have metrics right now that we've been working with the surgeons on in the IJRR program to develop the outpatient metrics and get data around that. And if you were to look at that as a whole service line, you would see very low readmission rates. And that's something we could definitely even add to this report. This report doesn't necessarily have to stick to all the rules of the HRRP CMS program. We could even update the slide or add one in that shows the whole service line, which I think would help the community and yourself and the board to understand the service line better.
Right. We understand that the knees that are done as inpatients are the selected high-risk patients. They're done inpatient because they need to be inpatient. So
Correct.
they're obviously going to have a greater likelihood of complications.
Yeah, Mary, I do think it is a good idea to show the whole patient population of our joints, because yes, as you'll hear in finance, we have in terms of the number of cases that we do on a monthly basis, and so I think it would be helpful to get that perspective.
Yeah. Yep, I think it's great for the community to see because it'll be reflective of the entire service line.
Thank you, Mary.
And they have great outcomes. Thank you.
Thank you very much, Mary. As you said to start off with, overall a very, very good report. Very, very good results on a lot of different areas. Thank you. Thank you very much.
I just want to echo that, as Mary said too, it's really a collaboration, and it's really been a collaboration with nursing and physicians and other staff everywhere working together, and so that has really shown in the progress that's been made.
Absolutely. Yep, it's the whole team. Yep. Thank you.
Thank you again. Now move on to our finance report. Before we hear that, I'd like to just express my thanks and the thanks of the board to Chris Henry. Chris will be presenting the finance report for the last time tonight. And Chris, it has been an absolute pleasure to work with you. It's been very, very pleasant, and you've done some tremendous work, and we appreciate all that you've done. We will miss hearing from you.
Well, thank you. You know, I'll miss working with all of you. You know, being part of this organization, it gets in your soul. It really does. So it's really been my privilege to work with you guys, the board, and for the benefit of this community. It's really, this is the kind of place people should work. And again, it's been my pleasure. You know, I'm turning over the reins to Tom McDonough, and, you know, I'm turning it over to somebody who's very competent, and I feel that the healthcare system's really lucky to have him. So I leave comfortably from that point of view, and, you know, again, this place will always have a special place in my heart. So, okay, so with that, I'll get started. Thank you for your kind words, though, Dr. Stewart. They're very much appreciated. So tonight we'll look at Washington Hospital's operating and financial results for January 2023. Okay, looking at our acute inpatient statistics, our inpatient average daily census for the month came in 10.7% higher than budget at 165.8. Our combined average daily census, which folds in our outpatient observation equivalent days, these are patients that are not considered inpatients but are still in a bed and being cared for. So that statistic came in 8.3% higher than budget at 173.8 patients on average. Admissions for the month were 865, about 48 higher than budget. And also we had higher than expected patient days as a result of those admissions. Patient days were 10.7% higher than budget at 5,141. Our outpatient observation equivalent days for the month were 24.6% lower in budget, following the trend we've seen all year, as there was a lot of work done in that area to get those patients into appropriate levels of care. Those came in at 248 for the month, or 81 below budget. And our average length of stay for January, just a little bit higher than budget at 5.86. We had anticipated 5.69 for the month. Moving into utilization, the case mix index for the month, which is our measure of the severity of the cases we saw in January, came in lower than budget at 1.531. We had deliveries that were about 11% lower than budget at 101, and that statistic has been up and down all year. So it was low. It was a low month in January. Cath lab cases continued to be lower than budget at 155, about 26% lower than budget, as we continue to recruit new physicians into that program. Outpatient visits in January were pretty close to budget at 8,423, and the emergency room continued to perform higher than budget, 340 visits, or 7.7% higher at 4,737. Taking a quick look at the details in the ORs and the cath lab. In surgical cases, again, higher than budget by 39. Joint replacement cases, really a big mover there, and as well as our other category. Joints were 25 higher than budget, and our other category came in 30 higher than budget. You can see neurosurgical cases and cardiac surgical cases combined to be lower than budget by about 16 cases. In the cath lab, really lower in all areas for January, as we've seen. The shining star there this year was our neurointerventional radiology cases were one higher than budget at 8. Into productivity. Productive FTEs for the month came in just a little bit above budget at 1,379. We had a lot of non-productive FTEs hit in January, and we really had a lot of people taking vacation. We didn't get a big spike in COVID this year like we've had the last several years. I think people really needed to take vacation during the holidays. So we ended the month with total FTEs about 3.7% higher than budget at 1,629.1. By the way, those non-productive FTEs included 2.4 FTEs related to the supplemental COVID sick leave program. That should be the end of it. So nice to get through that. Our FTEs per adjusted occupied bed, which is our productivity measure, came in lower than budget at 5.97. We had expected 6.37 in the budget. Moving into the financials, first we'll take a look at our Governmental Accounting Standards Board presentation. This is the format we're required to use for our audited financial statements. Total patient revenue for the month came in 3.8% higher than budget at $199,223,000. Our deductions as a percentage of revenue for the month came in at 77.76% against a budget of 77.04%. Quick look at the details there. We did have a rough payer mix in the month with governmental payers much higher than budget at 74.19%. We had budgeted for 71.8%, and as we've all know, government does not pay well. HMO for the month came in pretty close to budget. PPO was lower than budget. It came in at 21.7% against a budget of 24%. Private pay just slightly below budget. So we ended up with our contractual allowance, which includes all our insured patients, at 76.12% versus 75.14%. Our provision for bad debt and charity came in lower as a percentage of revenue at 1.64%. We had expected 1.90%. And again, total deductions at 77.76% versus a budget of 77.04%. So we ended the month with net operating revenue that was $171,000 higher than budget at $44,789,000. Our operating expenses for the month were about $1.6 million higher than budget. And there's a lot going on in the month. Our salaries and wages were higher with our higher FTEs, and also still using overtime and a lot of agency staff to fill in the gaps with the difficult labor market. Benefits for the month were $539,000 higher than budget. Health and welfare claims came in much lower than we've seen the last couple of months. They were about $137,000 higher than budget. But related to that, normally we would start to see stop-loss claims coming in this time of year. And while we've had a large number of claims hit during the year, we haven't had any hit stop-loss level. So we had expected to be bringing in stop-loss recoveries of about $63,000 this month, and it just hasn't materialized yet. That's a good thing. We're not having big catastrophic claims. It's good for us. It's good for our employees. So just not developing as we've seen over the past several years. We also had an unfavorable variance in FICA with our higher wages, and then a number of smaller with a number of variances that added up to the rest of that variance. Supplies for the month were $627,000 higher than budget. Biggest drivers there were prosthesis with our higher number of joints, and our drug costs were higher in the month related largely to activity in the infusion center. And then again, let's see, we had a number of smaller variances there that just added up to the rest of that variance. Pro fees and purchase services for the month were below budget by $116,000. Medical fees, consulting, legal, costs and repairs and maintenance were all lower than budget. Those were offset by some higher recruitment fees as we continue to try to get people in the door. We had some higher architectural fees related to the facilities master plan and some scanning costs in HR. Utilities, insurance, and other, that category down about $125,000. All year we've seen lower than expected utility costs. We just didn't see the increases that we expected there. Insurance was lower than we anticipated, and we've got some timing differences in the spending for marketing. So we ended up January with an operating bottom line of $39,000, lower than we had anticipated at one point, but just under $1.5 million. Non-operating income for the month came in at almost $1.6 million. That was largely driven by an unrealized gain in our investments for January, which we'll take. And that gives us a total bottom line of $1.6 million against a budget of $1.567 million from a GASB perspective. Moving into our Financial Accounting Standards Board presentation, and this includes adjustments that Wall Street might make to our GASB statements to make us comparable to GASB organizations. First thing we do is we reclassify $555,000 of revenue bond interest expense out of non-operating, where GASB requires it. FASB likes to see it into operating expenses. So we end up with an operating loss for January from a FASB perspective of $516,000. We then eliminate our general obligation bond interest expense. We eliminate the tax revenue that we collect to service that debt, and FASB won't let us keep that unrealized gain in our investments. They don't recognize that. So we end up with non-operating income from a FASB perspective of $232,000 and a total bottom line showing a loss of about $284,000 for January. Taking a quick look at earnings before interest, taxes, depreciation, and amortization. This gives us a kind of a snapshot of what kind of income we're producing to service debt and to do capital expenditures and program development. So we look at our operating bottom line before considering depreciation, because depreciation is a representation of cash flow that has already occurred, but we're recognizing the expense as we use up those assets. So we had EBITDA in January that was just under $3.7 million for the month. We then drop down to our non-operating category, and we pull out interest expense, and that leaves us with non-operating income of a little over $3.2 million. So in total, our operating and non-operating activities generated about $6.9 million, again, to support our debt service, our capital expenditures, and future program development. So that was January. Any questions?
Chris, I just wanted to understand that the bond rating agencies use the FASB numbers, correct?
Yes, they adjust
They
our...
don't care about GASB.
Yeah, well, they care, but really the majority of organizations follow FASB rules. Government has its own set of rules. So it really makes us comparable to the rest of the world. And yes, that's how they do it.
Thank you.
Yeah.
Thank you, Chris. I think we can move on now to our operations.
All right, it's my pleasure to present the preliminary operations report for February of 2023. So starting with our gross revenue, you're going to continue to see a lot of themes that Chris talked about in the January numbers. So gross revenue of $188.3 million for February was above the budget by $386,000. But was below February of 2022 by $6.2 million or 3.2%. Inpatient gross revenue of $108.3 million was below the budget by $7.4 million, or 6.4%, and $15.6 million, or 12.6% below February of 2022. This was really basically driven by the inpatient ancillary services, our cath lab services, and then also, even though surgical services were on budget, it's really due to the mix of the types of surgical cases we're seeing. Looking at our outpatient gross revenue of $80.1 million, it was above the budget by $7.8 million, or 10.7%, and $9.4 million, or 13.3% above February of 2022. What was driving this was outpatient ancillary services, and also surgical services revenue were above budget. I also want to note that in February, the Radiation Oncology Center began to operate as an outpatient department of the hospital, and which accounted for $3.4 million of the outpatient revenue. So.
Was that accounted for in the budget?
Yeah, so we weren't sure really when we were going to transition. So there was a little bit of revenue, gross revenue in, that you'll see that when we get to the volume numbers, we did not budget for that. So, so there was just a little bit of it budgeted for. We weren't sure on timing. Moving on to the key census statistics, the average length of stay of 5.56 was below the budget of 5.73, 5.17, or 3%. This was also lower than the February 2022 average length of stay of 6.38. So we had 15 discharges with lengths of stay greater than 30 days, ranging from 31 to 71 days. And if we exclude those outliers, the average length of stay was 4.89. So still in-house at the end of the month, we had 5 patients with length of stay over 30 days, and they range from 33, 35, 37, 40, and 97. So as I said, we have been really working on looking at ensuring that we have patients and transition them to the next level of care when it's their time. Our outpatient observation equivalent days at 265 were below the budget of 329 by 64 days, or 19.5%, and 23 days below February of 2022. And this is really consistent with the trend that Chris talked about in the previous month and we've been seeing over the last few months. Our inpatient average daily census of 167 was above the budget of 160.5. By 6.5, but below February of 2022 average daily census of 178. So when you look at the combined average daily census of 176.4, it was above the budget of 172.3 by 4.1, but 11.9 below the February of 2022 average daily census. Moving on to our admissions trends, as you can see, admissions of 866 were above the budget of 784 by 82, or 10.5%. February of 2023 admissions were 102, or 13.4% above February of 2022. And really, you'll see that mainly this favorable variance is driven by medical cases that we're seeing. Moving on to patient days, although our admissions are up to 10.5%, the average length of stay is down 4%, so resulting in our patient days of 4,675 being above the budget by 180, or 4%, so not at the same level as the admissions. Patient days were 310, or 6.2% below February of 2022. Looking at our days, adult med-surg days were higher than budget by 190 days, or 6.2. Our OB, peds, and special care nursery days were higher than budget by 130 days, and this is 33.9%. This is really driven by the SVM. We really had a number of babies throughout the month. They were very busy. And then we were low at IMC days were slightly below budget at 5.5%, and then we did see lower ICU days, and they were 19.8% below budget. Looking at our surgical trend for February, total surgeries in February were right on budget at 344, and the surgeries were 48, or 12.2% below February of 2022. Now, finance reassures me that inpatient surgeries at 130 were right on the budget of 130, and outpatient surgeries at 214 were right, consistent with the budget of 214. So they were right on budget. That's exactly.
First time in 23 years
Yeah.
that we've gotten both of those numbers.
All the numbers are yes. As you can see, I know we talked about our joint replacement surgeries, and as you can see, we had 157 for the month, and they were above budget by 15 or 10.6%, but were 2 or 1.3% below February of 2022. So the majority of them are outpatient surgeries. I do want to note there were 50 cases done at the Peninsula Surgery Center for February. Yeah. We still have a few more contracts that will have effective dates in March, but you know, we're starting to see the appropriate cases go there. Our neurosurgical cases were below budget by 8 or 25%, and were 7 or 22.6% below February of 2022. We did continue to have a few cancellations of cases during the month, and some of the physicians were out. Cardiac surgical cases were below budget by 3 or 21.4%, and were 4 or 26.7% below February of 2022. And then lastly, all other surgical cases combined were below budget by 4 or 2.6%, and 18.7% below February of 2022. And a lot of that is we saw a decrease in vascular cases there. So that's the same thing that's also hitting. We've continued to be challenged with the cath lab as we work on our recruitment. Our cath lab cases for February at 172 were 51 or 22.9% below the budget of 223, and 20.4% below February of 2022. Inpatient cases were 97. At 97 were 21.1% below the budget, and 17.1% below February of 2022. And the outpatient cases at 75 were 25% below the budget. And again, the two areas, and you'll see that broken down, that where we've been challenged is in both the vascular and the IR. So you can see that neuro IR cases were consistent with the budget, but and cardiac cases were just slightly below the budget, but really we're seeing the issue in non-vascular IR cases and peripheral vascular cases. Lower than budget. Our deliveries were slightly below budget. Again, I think we've seen these numbers go up and down over the last 6 months. And they came in at 107. They were below budget by 3 or 2.7%, but 19 or 21%, 21.6% above February of 2022. Moving on to our non-ER outpatient trend, visits of 8,681 were above the budget by 334 or 4%, and above February of 2022 by 689 or 8.6%. So one of the major pieces to this, as I mentioned, is the Radiation Oncology Center. We began the operations in February as a hospital outpatient department, and they saw 409 visits that month. So, and they were not included in the budget. So we did have lower volume in imaging, and also, again, we've continued to see lower in the lab because of less pre-op testing for the cath lab patients. Jump to that. Next is emergency room visits. We've continued to be busy in the emergency room. We had 4,424 visits, and they were above budget by 74 or 1.7%. And they were 569 or 14.8% above the prior year. We had 128 COVID positive patients, or 2.9% of visits, versus 75 COVID positive patients in February of 2022. So we did see a number of patients through the ED. Looking at a gross revenue recap, our surgical cases were consistent with budget. but revenue was above budget by about $694,000, 2%, and as we know, joint replacement cases were above budget. Our room and board revenue was below budget by $155,000 or 0.4%, and patient days were higher than budget by 4%. However, as I mentioned, ICU days were lower than budget by 19.8%, so that's driving down some of our room and board revenue. Deliveries were above budget by 3 or 2.7%, and revenue was below budget by $617,000. We are looking at the process of it. We're auditing those charges right now because I think that we may have some missing charges. So we are in that process of looking at that right now. Our emergency visits were above budget by 74 or 1.7%, and the revenue was above budget by $160,000 or 1.4%. Cath lab cases were below budget by 51, and revenue was $3.9 million lower than budget. And lastly, ancillary services revenue was above the budget by $4.2 million or 4.7%, and mentioned $3.4 million of it was due to the Radiation Oncology Center. Once again, we did have a challenging payer mix. As you can see, government-sponsored patient revenue made up 72.5% of total gross revenue. This was higher than the budget of 72.1 and lower than the prior year's percentage of 74.6. HMO was 2.1% of gross revenue, which was lower than the budget of 2.6%, but higher than the prior year's percentage of 1.3%. PPO was 22.8% of gross revenue, which was lower than the budget of 23.7%, but slightly higher than the prior year's percentage of 22.6%. As you can see, we did have a high private pay, was at 2.6% of gross revenue, which was higher than the budgeted 1.6% and higher than the prior year percentage of 1.5% of gross revenue. This is higher than usually that we see. We did have two high out-of-country accounts totaling over close to $1.8 million. That's really driving that private pay payer mix. And if you took those two cases out, we'd be back down to about 1.7%. So.
Those have been discharged?
Yes.
Both of them have?
Yes.
Okay, they both of them, yeah. All right, moving on to the preliminary productivity indicators. You can see the productive FTEs were above budget by 30.2 or 2.1% at 1,486.7. Non-productive FTEs were below budget by 8.9 or 5.3% at 159.2. The total FTEs of 1,645.9 were above budget by 21.3 or 1.3%. Our productive FTEs per AO adjusted occupied bed came in at 5.12, which was lower than the budget of 5.58 and lower than the prior year of 5.36. And also total FTEs per adjusted occupied bed came in at 5.67, which was lower than the budget of 6.23 by 9% or 0.56. I think we also still, though, have some opportunities in terms of looking at our FTEs and ensuring that in the areas that we flexed appropriately. So I know we've been talking about that. Moving on to our outpatient statistics, our Whitman Clinic visits were below budget in February by 909 or 5.4%, at 16,042. And 2.3% below February of 2022. The biggest driver, I should say, of this is we really, when we did the budget, weren't sure how many COVID visits were to budget. So we are actually down 637 COVID visits. So it's a large amount of visits, 55.9% in terms of our COVID visits. We just weren't sure where things would be. We're down 3.3% in primary care visits. We do have an open position, and we had some physicians that took some time off, and we were down 0.6% in specialist visits. But the main driver was the COVID visits that we were down. Looking at our DevCo outpatient visits of 2,087, we were above budget by 249 or 13.5% for February, and 271 above February of 2022. We've really seen the Washington Outpatient Rehab Centers. You can see they were above budget by 23.5%. Then the Washington Outpatient Surgery Center visits were slightly below budget by 22 at 4.7. As mentioned, our Peninsula Surgery Center visits were below budget by 50 at 50, but they have been steadily increasing. And lastly, Ohlone College student health visits were above the budget by 25. Moving on to our key financial statistics. You can see our days cash on hand for February ended up at 147 days, a decrease of 3 days from the prior month, and also it's 12 days lower than the same period in the prior year. There were two things that were driving this. First is our quality incentive program known as QUIP, and this is for the incentive program for public hospitals that we participate in. And it was, as I've mentioned in the past, we've done very well with the program. So in order to get the funding, we had to contribute the $2.6 million. It's about 2 days. And so in May, we expect to receive approximately $8.3 million back. Wow. So as mentioned, we feel that we're going to receive over $5 million, but we need to, it's part of the program we have to, we have to put it in. And
we are, if not the best,
probably
top tier in performance in the whole state.
Yeah.
So it's well worth it.
It is very much well worth it. Yep. So that's been what was accounted for the 2 days, and then we did also see some change in reduction in market value of investments in February too. Our days in accounts receivable in February were 57.8. It's slightly higher than the prior month by 0.3 days, but 10.9 days lower than the prior year. So it's an area we continue to work on. And there were 407,000 in charity care adjustments for February of 2023. There were 3 large accounts that represented 322,000. In total, there were 29 accounts written off for charity care. So that is my report for February.
Thank you, Mary and Chris. And again, Chris, thank you.
Thank you. Yes.
It's really been my privilege. It really has.
It's a wonderful thing.
We've enjoyed it all.
Yeah.
Wish you the best.
Thank you.
Really.
Thank you.
Keep in touch.
I shall. Well, we're not going away. We're coming here to get our health care.
Remember that, Larry.
We'll take that as the highest compliment.
Yes.
Thank you.
Yes.
Thank you, Chris.
Take good care of you, Chris.
Now move on to our calendar.
All right, I have a few things. I'd like to start with Employee of the Month for March of 2023. It's my pleasure to introduce Christian Deary. He's the supply chain associate in materials management. Christian became part of the Washington Hospital family in March of 2020. He graduated from UC Davis with a bachelor's in neurobiology, physiology, and behavior. As a supply chain associate, Christian has become an integral part of our operations to keep the department stocked with supplies on a daily basis. The clinical departments have given solid praise for his ability to deliver supplies when requested and in a timely manner. We often hear, quote, "He is always courteous and delivers with a smile." Christian is always willing to help within the department to make sure operations run smoothly. He is ready to step in whenever and wherever needed. When not at work, Christian enjoys time with family and enjoying adventures. He recently went on a trip that included skydiving. Yeah, I know, I was curious about that.
You got to be careful.
I know, I stay with my feet on the ground. Yeah. We hope Christian stays with the Washington Hospital team for a long time as he develops his career opportunities with us. So. All right, now moving on to the calendar, I just have a few things. I do want to just talk about the past 4 community outreach programs since our last meeting. He's bringing it up. All right, as you can see, we had a couple of educational programs. One was by Dr. Sunil Upender, and these all took place. They still are taking place on Facebook Live and YouTube. And as you can see, we had 92 live views and 483 accessed later, and that was a lung cancer detection with low-dose CT. We also worked and provided coverage for Special Olympics basketball at Newark Memorial High School and through our athletic trainers, and we had 236 athletes participated. And then two other educations we provided. Dr. Rohit Sehgal provided Staying Heart Healthy. You can see we had 143 live views and 438 people accessed later. And then lastly, Maria Nunes, our clinical manager of stroke, presented at Cozier Retirement Community. So those were the ones we did. Coming up, we have a number of education sessions coming up that are open to the community. On March 8th, you can see we have Dr. Khalsa, who's doing Life After Stroke, and these three, there are three that are on Facebook Live, and then we do have a hybrid one that we are going to be doing both in the auditoriums and on Facebook Live and YouTube. So the March 8th is on Facebook. March 15th, Dr. Mark Hsu is urologist, is presenting common urology concerns. We have Dr. Bryant Bonner, orthopedic surgeon, who's going to be talking about robotic-assisted knee replacement on March 16th. Then we have March 22nd, Dr. Niru Kumar, who is going to be talking about mood and anxiety disorders and breaking that stigma. And lastly, as you can see on April 4th, we have Dr. Rajiv Saigal, spine and neurosurgery. He's going to be talking about the aging spine, and that's the hybrid event. And then, of course, you can see we do have other presentations that are going to be, Dr. Hsu is going to be at Acacia Creek, and then Lisa Curry is going to be doing it at Vintage Court. Vaccination clinic, you can see we're getting close to almost hitting 100,000. We're at 98,773 vaccine doses given. For the 6 months for adults and 6 months to 4 years, 882, and 5 to 11-year-olds, 3,869. So we have seen some slowdown with that. I do just want to remind the board that and the community that we are holding our 36th annual golf tournament that will be supporting surgical services, and that will be happening on May 4th at the club at Castlewood. So additional information and to sign up can be found on our website. And that we continue to hold our host free charitable giving and estate planning seminars, and our next one is June 21st at 5 p.m. And then lastly, I just want to let everybody know that Washington on Monday, March 6th, hosted the Legislator of the Year Award that was given to Congressman Ro Khanna. And it was given by the California Special District Association. And as a healthcare district, we are part of that association, just as other districts are too. So we're very happy to recognize Congressman Ro Khanna. He's been a great friend of the healthcare system. And that is my report.
Thank you, Kimberly. Thank you very much. Do we have any announcements this evening that need to be made?
No, I do not.
We have no announcements. Now I have a very pleasurable report, and that is that there's no need tonight for a closed session. And there being no further business, this meeting is now adjourned.
Okay.
Thank you all for your attendance.
Thank you.
Thank you.